we'll do it that way, and your questions will be answered. I don't know that we can answer all your questions, but we'll try. And I also want to thank our sponsor this morning, which is Amgen is the sole sponsor of this event this morning, and they'll actually be sponsoring 8 more of these. We do have a total of 18 migraine education days this year. We encourage you to attend as many as possible. They're free. Right now, because they're all virtual, we can be changing the topics. So we're going to have a whole host of different topics. So come back and also take a look at our website so that you can possibly come and do a virtual walk, run, or just relax. We're really excited about that. We're going to be making a virtual photo album. We're going to see how many miles can you move for migraine. What's it worth to you to either move? You don't have to move. You can just relax. And Helen, hopefully I didn't skip anything. Helen's here. She's saying now. I've got her muted. Sorry, Helen. Okay, with that, I am going to hand the microphone over to Dr. Watson, who is going to give us an update on migraine treatment and other things. Dr. Watson.
All right. Thank you, Shirley. Everybody just give me a thumbs up if you can hear me all right. All right, good.
Can hear you.
So just a few things. I'm going to, first of all, just thank you guys for doing this. This is an interesting time for all of us. I've got behind me my kids' Lego collection. So in honor of the struggles in New York City, you may be able to see the Statue of Liberty and Empire State Building. Also, since we can't travel anymore, all of these various landmarks around the world, so I can feel like I'm still out and about. On the talk today, I'll just ask for a little bit of grace in that this presentation is not quite as good as I would have liked it to have been, but given with my change in duties at work with trying to convert everything that we do over to telemedicine, I wasn't able to put quite as much time into this as I would have liked. So hopefully it still is effective, but if I say something a little bit stupid, I'm going to ask you to forgive me for that. But just like Shirley said, I'm from Morgantown, West Virginia, where I started the WVU Headache Center. I'm now the chair of the Department of Neurology. We are working hard there to do the best we can at this point, using telemedicine to take care of our patients, which is a new world for all of us, but we're getting there. So with that, I'm going to go ahead and get started. Today, well, maybe I'm going to get started. Let's see here. Sorry. There we go. All right. So basically, we're going to try to go through, talk very briefly just about migraine in general, talk about the current treatment options that are out there, and then talk about some of the newer things that are out there. Some of this stuff I will skip through fairly quickly because I'm sure a lot of you know it already, but just want to touch base on a lot of things. As you know, there's probably about 40 million people in the United States who have migraine disease. It is a 3-to-1 female to male disease for reasons that are not entirely clear. And about a quarter of households are affected by migraine, and the prevalence peaks in the mid-20s to mid-50s. I won't go through all of this. You guys know what migraine is because you're probably on here because you have it. But this is the criteria that we use to diagnose people with migraine in general. Migraine without aura is a headache that can last anywhere from 4 to 72 hours. Oftentimes that 72 hours gets blown past to much longer than that. Typically, we look for a one-sided headache, although that's not actually all that specific, pulsating or throbbing in quality, moderate to severe in intensity, and the big one is really the aggravation or avoidance of routine physical activity. That's where a lot of the disability of migraine comes into play, is that just doing regular things makes it worse. People with migraine frequently have nausea with or without vomiting, light and sound sensitivity. Migraine with aura is very similar, other than the addition of a reversible neurologic symptom that is attached to the attack. This is most frequently visual, people with flashing lights, flickering lights, loss of vision, but it can be sensory, it can be speech changes, loss of speech, people can have weakness, people can have dizziness, passing out. There's a variety of things that can go along with it. Typical aura lasts less than an hour, but again, these things are all, when I say typical, that doesn't mean always. And then chronic migraine is defined as having 15 days or more a month of headache, with 8 of those days meeting criteria for migraine. That comes into play a little bit when we talk about certain treatment options, which we'll get to later. All right, so what are the treatment options that we have that have been around for a while? Probably the tried and true that's been out are triptans. Things, and you'll see them there. There's 7 different triptan molecules available. They come in a variety of different dosing options and delivery options. All 7 of them have a pill version. Sumatriptan and zolmitriptan have a nasal spray option. Some of them have, sumatriptan has an injectable option, and some of them have a melting tablet option as well. In addition, there is a combination of sumatriptan with naproxen in one single tablet that is useful for some folks. I think the important thing to look at that really from a patient perspective is that there's a lot of options. And I just know from my standpoint, I see people oftentimes who come in saying they've tried everything. And when I really go through this list, they've tried 2 or 3, and that was everything that whoever they were seeing before could think of. And sometimes we will go through 4 or 5 until we find the one that's effective. And so triptans remain an acute treatment option for a lot of people, and there are a lot of options. Some of the other non-triptan options, and this is not intended to be entirely inclusive of everything, but DHE45, you may have heard this as Migranol nasal spray, but it's also commonly used in the hospital setting in an IV to try to break a cycle of migraine. It can be given IV, subcutaneous, intramuscular, or nasal, which can make it very useful in certain settings. Non-steroidal anti-inflammatories, from as routine as naproxen and ibuprofen for some people, ketorolac, which is Toradol and injectable. But these, for many people, actually are effective. But again, none of these things are effective for everyone. Antiemetics or anti-nausea medicines, so prochlorperazine, which is compazine, metoclopramide, Reglan, antihistamines, and muscle relaxers are sometimes used. In general, we try to avoid things that are opioids or butalbital containing for 2 reasons. One is the risk of addiction. The other is a risk of actually worsening the disease with use over time. Caffeine, again, if you have migraine once or twice a month and you use caffeine, that's probably not a big deal. But if you have a migraine attack that occurs on a somewhat frequent basis, caffeine can actually lead to worsening and more frequent attacks. And then benzodiazepines, which are oftentimes used to help people sleep, or again, on a rare basis may be okay, but on a frequent basis actually have some evidence for making the overall condition worse. If we transition over to preventive options, again, it's a long list. You guys are familiar with a lot of this, but on the anti-seizure medicine, valproic acid, which is Depakote, topiramate, these are the 2 that are FDA approved. I would say topiramate is used way more than valproic acid is at this point. Excuse me. And then others like zonisamide, gabapentin, lamotrigine, these are not FDA approved, but are used sometimes. People wanting topiramate will frequently talk about tingling, fingers and toes, sometimes around the mouth. It's like a sensation like when your foot's falling asleep and it's waking up. Topamax can cause that sometimes. It does have a tendency to reduce appetite and make certain foods taste weird. So anything carbonated will taste flat or metallic. And then just as a, for me, zonisamide, which is Zonegran, if people respond well to pyramate but can't tolerate the side effects, frequently a transition to zonisamide can be an effective transition where its side effects are similar but a lot less common, and so we can transition folks sometimes. Beta blockers, which are blood pressure medicines, propranolol, timolol, nadolol. These are very commonly used. We have to be a little bit careful with its effect on blood pressure if you don't have high blood pressure. It can also depress mood in some people, so there's some cautions with it, but it's generally a very safe drug and can be effective. Tricyclic antidepressants, which are old antidepressants. Nobody ever uses them anymore for depression, really, but they're still around because they're good for migraine, they're good for sleep, they're good for other types of pain. Amitriptyline is the one most commonly used, and generally at doses that were well below the doses that were used in depression, which means that the side effects do tend to be a little more tolerable. The most common one is that it induces sleep, which can also be helpful actually for some folks. The SNRIs, which are serotonin and norepinephrine reuptake inhibitors, these are newer, somewhat newer antidepressants. Venlafaxine is the one that is seems to have the best evidence in migraine. And then some of the other SSRIs get used, but honestly, the data on them is not very, very impressive for prevention of migraine, but we use them sometimes. People have used nonsteroidals, muscle relaxers, MAOIs, which I personally don't ever use because there's lots of then contraindications to their use, but they do get used sometimes. And then botulinum toxin or Botox is a common one for chronic migraine. These are just some of the herbal or natural things that are out there that have some suggestion that they're effective. The data on these is all very limited just because there's not a big company behind them pushing research, but we certainly use a lot of magnesium, tends to be well tolerated. Riboflavin, which is vitamin B2, and then butterbur, coenzyme Q10, and even every now and then feverfew can be effective in some folks. I don't want to get into the weeds of this too much, but the American Academy of Neurology and the American Headache Society put out some guidelines kind of grading the level of evidence for these drugs. And just imagine that level A means it's pretty good and level B means it's probably good. So they say that things that are level A are valproic acid or Depakote, topiramate, the beta blockers, and even actually using short-acting or long-acting triptans like frovatriptan for women who have menstrual-related migraine. Level B gets into more of the antidepressants like amitriptyline, some different beta blockers, and even some other triptans used as preventives. And just to show that we don't really, there's not consensus on everything, the Canadian Headache Society put their own out, and there are some differences. They ranked amitriptyline and gabapentin much better. They put valproic acid or Depakote much lower. So some of this stuff is up for interpretation, and that's why we use evidence-based medicine as best we can, but sometimes there is a little bit of trial and error in what we do. Botox, you guys probably have heard of or had or know of Botox. The big thing to remember is that it's not approved for prevention in episodic migraine, so you do have to have a diagnosis of chronic migraine to get it approved. There were a couple of large studies that looked at a fixed site, fixed dose, meaning that everybody in the trial got basically the same injections, although there was some wiggle room with some extra units. And they showed a pretty decent reduction in headache days and in headache hours compared to before Botox and compared to placebo. It's generally well tolerated. People get side effects of neck pain. Every now and then people get a headache afterward. You'd imagine if you have migraine and someone's going to stick a needle into your scalp 31 times, that might induce a migraine attack that day. It certainly does happen, and we have to deal with that. But despite that, my patients keep coming back for it because the benefits, the other 89 days of the cycle, are worth it for that one day of triggered attack. The advantages are that it's not oral, so it doesn't interact with very many medications. The insurance coverage for it is actually pretty good now, so it's becoming more and more available for folks. Oftentimes, though, there is an out-of-pocket expense that can be somewhat steep for patients depending on their insurance. It is 31 shots. I've yet to find anybody who loves it, and I look forward to the day when there is a non-injectable way of doing this, but we don't have that yet. From a physician standpoint, the documentation requirements are kind of annoying, but that doesn't really affect the patient side of it at all. I just want to transition now actually into what's new and touch base on some of this. We've really in the past 2 years had an amazing explosion of new treatment options for migraine disease, and it's been a pretty exciting time in our new options. Probably the biggest part of that have been things that affect calcitonin gene-related peptide. So CGRP, which causes dilation of blood vessels, it's involved in the transmission of sensation back into the brain, and it's very common in the trigeminal system, which is the sensory system for the head and face. And the levels of CGRP are elevated during migraine attacks. So for many, many years, people have been trying to find successful ways of blocking CGRP. And there were four drugs that got somewhat through the process and then failed. I actually remember as a resident a long time ago hearing about olkegepant. It was an IV drug. Actually, it looked like it worked well in an IV form, but they could not get it. Couldn't figure out how to get it into an oral form, and it just disappeared. The others ended up having some issues with liver toxicity, and then finally we had some success. Two medications have just hit the market really in the past few months that are CGRP receptor antagonists for the acute treatment of migraine. Ubrogepant or Ubrelvy. This is a 50 or 100 milligram tablet, although most people will be on 50 milligram. You only use the 100 milligram tablet if you're on certain other medications that aren't very commonly used. You can repeat it in 2 hours. You can actually take it up to 4 times in a day if needed. The data on it shows that about 20% of people are pain-free at 2 hours and 60% have pain relief at 2 hours. And a lot of people look at that 20% pain-free at 2 hours and say, well, that's not a very exciting number. And it's true, it's not a very exciting number, but it's actually pretty standard when we look at migraine acute treatments, that the pain-free rates at 2 hours, it's a pretty high standard to have. And so it is an important number that we look at, but the pain relief is also important. Most common side effect with Ubrelvy is nausea, and it's not actually very common. Rimegepant, which is Nurtec ODT, it's a 75 milligram pill that is dissolvable. It's actually 1 dose, and it has very similar looking efficacy numbers, 21% pain-free at 2 hours, 59% pain relief at 2 hours. And again, nausea is the most common side effect, and that's only 2%. If we stay on the CGRP track and look at the monoclonal antibodies, and in my opinion, this has been the biggest game changer in migraine medication, probably since sumatriptan was developed 20 some years ago. These are antibodies that block either the molecule or the receptor for the molecule around the brain and in the blood. The first one to hit the market was Irenumab or Aimovig. There are now 4 of them. Now the eptinezumab or Vyepti is an IV. It's a once every 3 month IV treatment. It has just recently become available. I personally have not had any experience with it yet, partly because I haven't seen any patients in clinic. So it's hard to start an IV treatment when we aren't allowed to see people face to face these days. But we will be getting some experience with that, and it has some very interesting data with what looks to be very rapid effect on preventing migraine attacks. The other three, Emgality, Aimovig, and Ajovy, are injections that are once a month, although Ajovy has the option of being either one shot once a month or 3 shots every 3 months. And the data on these is all pretty similar. They're very effective in preventing migraine attacks. And I would say actually, in my clinical experience, these are more effective than the data suggests that they are. When we first started using these, of course, we were only able to give them to our patients who had really been through everything else. And so we'd selected out some of our most difficult migraine disease patients, and we were seeing some pretty significant results in folks that I was honestly a little bit surprised that it worked as well as it did. Again, none of this stuff works for everybody, and everyone, we're still learning exactly how to use them and how to choose the right patient for each one, but these are certainly good options for folks as long as you have an insurance that will cover them. So another new acute treatment, 5-HT1F, which is a serotonin receptor. It's a little bit different than the triptans. These are called ditans, and lasmiditan is the one that has been recently FDA approved. It has clinical effectiveness that's pretty similar to the triptans, although it doesn't seem to have the vasoconstrictive effect. So it is presumed to be safer in people that have heart disease or stroke or other vascular diseases. Although I don't believe that it actually says that officially in the package insert, but that is the suspicion that it's a safer option. Again, it does have side effects. Dizziness is a common complaint, and the biggest problem with it is driving restrictions. The FDA put in the information an 8-hour restriction on driving after taking it because it does affect people's ability to drive safely. So again, maybe not a great option if you need to go somewhere, but if you're able to stay put, it does seem to be a good option for some folks. The other thing that is really becoming more and more prevalent in migraine disease these days is neuromodulation, which, how can we affect the brain positively without using drugs or chemicals? And so there are definitions on here, the alteration of nerve activity through targeted delivery of a stimulus, such as electrical stimulation or chemical agents, to specific neurologic sites in the body. Anyway, that's a lot of big words. I'm not even sure what they all mean, but when we look at neuromodulation and headache disorders, there are a number of options, and we're going to talk about a variety of these. We're really going to talk about the non-invasive options today: transcranial magnetic stimulation, external trigeminal nerve stimulation, non-invasive vagus nerve stimulation, and then peripheral electrical stimulation. There is some data out there on occipital nerve stimulation, but that is an invasive procedure, and I think just we can save that one for a different day. Transcranial magnetic stimulation has been around in research for quite a long time. It's very well known that you can use a magnetic pulse to affect electrical activity in the brain. It became available in migraine a few years ago. It can be both an abortive or a preventive treatment. They do have some good studies on the abortive side and some reasonably good studies on the preventive side. Typically, the stimulation causes some tingling, maybe some ringing in the ears or lightheadedness, but in general, most people tolerate it well. The mechanism is, the idea is that you're using a magnetic wave to disrupt this electrical activity in the brain that is inducing migraine or inducing migraine aura, called cortical spreading depression. The effectiveness, so in this slide, sham means a device that actually didn't do anything, but was designed to appear like it was an actual device, versus the TMS device. And what we're looking at, the y-axis is the proportion of patients who became pain-free at different time intervals. So here you see pain-free at 2 hours, up around the 40% mark. But again, these are people who are treating early, treating ARA. So it's a little bit different than when we're looking at some of the medication pain-free numbers, where people had to have moderate to severe pain before they treated. So, and not to minimize either data point, but they aren't necessarily comparable one to the other. But it's a pretty interesting number that people at 2 hours were pain-free at about 40% of the time. And then this is a reduction in headache days on the preventive side of it, that people had a reduction in headache days of around 3 days per month with the use of the transcranial magnetic stimulation. Challenges of it are that the cost, insurance companies have not really bought into neuromodulation very much at all, certainly not in headache disorders. So there's a device that you have to buy, and there's a maintenance cost to it. Portability, I mean, the device is not huge, but it would take up a lot of space in a purse. And if you don't carry a purse, I'm not sure how you'd carry it around. And the effect, I think, is modest, although it's something. The benefits, though, are, again, it's not a drug, and anything that we can do without giving people more drugs, I think, is potentially advantageous. It is very well tolerated. You don't have to worry about cardiac limitations, and does not seem to have any potential to cause rebound headache. External trigeminal nerve stimulation, or the Cephally device, again, is another non-invasive device, can be used preventatively and acutely. Has some good studies looking at prevention, and some okay studies looking at acute treatment. It has been reported to cause some problems with sleep, and some tingling in the area of the forehead. It rests on the forehead, and it stimulates the supratrochlear and supraorbital nerves, which are the two nerves that kind of provide sensation to this part of the head on either side. And it is basically a TENS unit that is safe to use on the head, because regular TENS units are not designed to be used on the head and have some potential risk, but this one is designed to be safe for that. The data, the word on the picture on the left, the word Verum, it means the actual treatment versus sham. And what you see is a reduction in the number of migraine days of about 2 by the time you get to the 3rd month of consistent use. And that about, people had about a 25% reduction in migraine days at the end of the trial with it, as well as a 30-some% reduction in total headache days. So some overall reasonably good data for something that's not going to cause a lot of other problems. Challenges, again, insurance and the cost of it can be challenging for some folks. It does require a prescription in the United States, and in my opinion, the data on it is statistically significant, but from a population standpoint, it's clinically questionable, although I certainly have patients who use it and feel like it works well for them. So if someone wants to try it, I am all for them giving it a shot. Benefits, it's very safe, it's very tolerable. Once you buy it, the maintenance cost of it is pretty low, and so it really is just the initial expense of getting it. The next neuromodulation option out there is non-invasive vagus nerve stimulation. This is also called GammaCore. It's an abortive treatment. It has good studies looking at its benefit. Some side effects, including some pulling and twitching of the face, because you put the device on your neck and it's electrical stimulus that you can feel. And so it can have some spread of the electrical impulse and affect the muscles and nerves around it. Some people reported some dizziness and neck pain. The idea is that it modulates the central pain centers through the nucleus tractus solitarius, input from the vagus nerve. It basically feeds back into the brain and tries to turn down migraine attacks. Again, data on it is reasonably good compared to other options. And I'll point out just on the slide on the left, picture on the left, people who were pain-free at 120 minutes or 2 hours, about 30%. So I think that that for a lot of folks makes it a reasonable option. About 40% of people had pain relief at 2 hours. And then the last one we'll talk about is peripheral electrical stimulation or remote electrical neuromodulation. There are different terms for it. And this is the Nerivio device. This is a non-invasive abortive treatment with good studies. And the main side effect is that you can feel it. It is an electrical impulse. You put the device on your arm and turn it on. You control it with your phone, the intensity, and let it run for 45 minutes to try to abort a migraine attack. Basically, it feeds, it turns on in a non-painful way. It turns on the pain nerves in your arm that feed back into the central pain mechanisms of the brain and try to turn on the brain's pain dampening or pain modulating effect to then turn off migraine. It's a pretty interesting way of trying to do that by using your pain mechanism basically to your advantage. The data on it again is pretty good. Pain relief at 2 hours was above 60%. Pain-free at 2 hours was between 30 to 40%. Again, these are in people who had any level of pain from mild, moderate, or severe. So it's a little bit different than some of the drug studies that you had to be moderate to severe pain before you could treat. But I think, again, it's got good data and makes it a viable option for a lot of folks. We run into the same challenges, cost and coverage. It's always a challenge with anything, but in particular with devices instead of medications. Some people have struggled with comfort with it because you do have to get it to the point that you can feel it. But you're supposed to adjust the pain down to where it's not painful, but that's a delicate balance of, is it strong enough but not so strong to be painful? It does require the use of a smartphone, and even in 2020, that isn't everybody. So that can be somewhat challenging. It's very safe, very effective, which are its benefits. So with that, I'm going to wrap up, if that's okay, and we'll take questions if there are any. But migraine is a common disease, usually manifests as episodes of severe disabling pain with other symptoms and environmental sensitivities. Wide range of available treatment options, and that range of options is continuing to expand. It seems like at this point, every couple of months, there's a new treatment option out there, which is very exciting. And someday those treatment options will become more standard as we figure out how to use them and insurers and figure out how to cover them. And with that, I will stop.
Okay, thanks, Dr. Watson. I've got the questions here. The first question is, in the time of this pandemic, is it safe to take an anti-CGRP injectable? I think perhaps this question is referring to the reduction that some people are talking about. Is there possibly a reduction in your with the monoclonal antibodies to fight off infection?
Right. As far as we know, which again, this is very new territory for us, but as far as we know, these medications do not have an impact on the part of your immune system needed to fight infection. Now, in saying that, there are some people who have chosen to stop taking them during this time. I don't think, personally, I think that being ill from having recurrent migraine attacks is probably a bigger risk factor than being on a CGRP antibody when it comes to your likelihood of contracting and being able to fight off coronavirus.
Okay, thank you. And I just want to let everyone know, if you can type your questions into the chat box, we can take a few more questions. So go ahead and type them in now. The next question is, what did the clinical trials look like for Rayval?
I'm trying to remember them off the top of my head. They look similar to all of the other clinical trials, which is that they work for an awful lot of folks. You know, every time a new treatment option comes out, I look at the data, and there's a part of me that kind of, you know, is depressed isn't the right word, but it, you know, no one's come out with a drug that says this will make 75% of the people pain-free in 2 hours, right? That just doesn't exist yet. But what we're looking for are things that show the potential of being effective for a significant portion of people, more effective than placebo. Because remember, you know, in these studies, you take 100 people, and let's say 20 of those 100 people then are pain-free at 2 hours. That means that 20 people, the drug is 100% effective. So, I mean, it is it's, even though we always look at things kind of as a population number, and it can depress the effectiveness the way it looks. If you're in that group of people that do respond, it doesn't really matter if it's 20% effective or 40% effective. For you, it's effective. And so we continue to, you know, we see these numbers that are they don't blow us out of the water, but they are new tools and new options.
Okay, good, thanks. Okay, the next question is for the CGRP blocker that is the abortive, and if you're on a CGRP antagonist preventively, how much CGRP, you know, if you're blocking too much CGRP, can that be a problem?
Well, we don't think so at this point. The degree of blockade of CGRP with the antibodies is not anywhere near 100%. So we aren't shutting down the effectiveness of CGRP entirely. These drugs don't even actually get into the brain very well, and so, you know, one of the questions is why do they work so well when they don't even get into the place that seems to be the problem? And I don't think we have a good answer for that. But you know, we have CGRP for a reason. I don't know what that reason is, but, you know, otherwise it wouldn't be in our bodies to start with. So if you went through and you just completely wiped it out, that might actually cause problems. But with what we're talking about with the modest block of the CGRP antibodies, and then using a CGRP receptor antagonist on top of that acutely, I don't see any risk to that to people, because that blockade is a short-lasting blockade anyway. So I don't think that it's a concern.
Okay, thank you. Next question is on this neuromodulation devices. Is there any reason not to be able to use, if you're that fortunate, I guess, to use all of them in the same day, or?
I mean, if you won the lottery recently, I guess there's no good reason not to use all of them. I'm trying to think if there would be any contraindication. I mean, to some extent, I guess my only concern would be all of these do have some electrical effect on brain activity. And when you start combining things that we haven't really looked at, the combination, you know, could there be a risk of short circuiting something? I mean, maybe, but I think it's pretty low risk, because all of these options are pretty low risk. I wouldn't want to use them at the same time, because I think that, you know, if there was some sort of risk of cross effect, you know, I wouldn't have the Cephally device on and use the TMS at the same time. I think that could potentially, in theory at least, cause too much change in electrical activity, which could create some problem.
Okay. And then we have one more question, and that is, can a low dose of Klonopin cause rebound, such as 0.5 milligrams per day?
So Klonopin, it's not clear. The advantage of Klonopin is that it's a very long-acting benzodiazepine. And so the longer the acting the drug, the less likely it is to cause rebound. I don't know for sure about Klonopin. I know that things like Valium and Ativan and Xanax, probably Xanax is the worst of those, has a tendency to lead to worse headaches. Klonopin is probably, if you're going to be on a benzodiazepine, probably the least likely one to do that. But yeah, so the answer is I don't know for sure, but if you're going to be on one, that's probably the best one to be on.
Okay. That is all of our questions. That's all we have time for today, actually. And I'm going to give you a round of applause like what we do when we're at champ meetings. So this is our quiet clapping. And I want to thank you for your time and being here. People are writing in saying that was wonderful. Thank you very much.
Good,
and
thanks.
we're going to transition into Anika Salim in just a minute. I just want to take another moment to thank you, Dr. Watson, for being here. For those of you that don't know, Dr. Watson is actually a board member of Miles for Migraine. He practices in Morgantown, West Virginia. And we will be having a walk, run, just relax event in Morgantown, West Virginia this year. Hopefully it'll be a live event, but we'll see. So thanks again.